My name's Dr. Adrian Brady. I'm a consultant cardiologist in Glasgow, an associate professor and president-elect of the British Hypertension Society. Hypertension of the heart, in really just a few words, hypertension drives left ventricular hypertrophy, which we all know. It drives atrial fibrillation. It leads to coronary heart disease and heart attacks. And it leads to heart failure. And these are the cornerstones in my mind when I'm thinking about treating individual patients with hypertension. I think if I leave them untreated, that's at risk of an MI, heart failure later, particularly in women, and atrial fibrillation for many. And so those are the real cornerstones, apart from stroke, for treating hypertension in an otherwise well individual. Will reduce stroke by at least 50%, and will reduce coronary events perhaps by as much as 40%, and heart failure substantially as well. So these are really the little vignettes of thought in my mind when I'm seeing an individual with high blood pressure and explaining why I'm going to treat their blood pressure. They say, well, what difference does it matter? It's to lower blood pressure, to reduce stroke first and foremost, and secondly to reduce the cardiac long-term sequelae, which are heart failure, myocardial infarction, atrial fibrillation. Renal function will be discussed by other members. Is there any particular drug which is much better than others? Well, there have been meta-analyses that have come and gone over the years. The key thing is to lower blood pressure. Which drug that we choose or which combination of drugs, the British Hypertension Society, nice guidance, the current one, gives us exactly the pathway which we should choose. What about hypertension among patients with established coronary heart disease? Well, for these people who have angina and hypertension, then beta blockers are our first choice. We know they lower blood pressure, they reduce plasma renin, plus they reduce slightly the risk of myocardial infarction, and certainly in people with previous MI, they reduce the risk of reinfarction and of sudden cardiac death. So beta blockers are our first choice, and then above that, we really add drugs, usually an ACE inhibitor next, and then diuretics as required. Heart failure, we've got abundant evidence for ACE inhibitors and angiotensin receptor blockers as first-line therapy. Quickly be adding beta blockers, quickly be adding mineralocorticoid receptor antagonists, for example, spironolactone or perhaps eplerenone, and then into the more esoteric side of cardiology with resynchronization therapy for these people with hypertension, heart failure. Hypertension, funnily enough, if you have heart failure, to have a maintained blood pressure is quite a good sign. And so if somebody has the blood pressure 140/80 and has heart failure, in fact, that's a better sign than somebody who has a blood pressure of 90/60. So that's a useful thing to remember, that to have a little bit of blood pressure if you have heart failure is a good thing.